Thank you, Giorgio. Thank you for this kind of introduction and for this invitation. Well, I would like to start with a question to the audience. What was the most frequent complication of bronchoscopy until a few years ago? Somebody could say pneumothorax, somebody else hemoptysis. Well, it's wrong. The most frequent complication of bronchoscopy until few years ago was do not get diagnosis. That means useless examination. But in the last year, things have changed, as you know, and particularly this subtyping of non-small cell lung cancer now is a very important marker, and also, as you know, we have a therapy that is oriented versus the oncogenic drivers. So our question changed today. What is the most frequent complication of bronchoscopy today? Not only do not get diagnosis, but also do not get adequate material suitable for histotype definition and for molecular evaluation. This means that all the pulmonologists that perform bronchoscopy had a revolution in the last year. The majority of previous papers concerning the sensitivity of bronchoscopic techniques in lung cancer should be revisited, because in that paper we saw that one cell making possible diagnosis of non-small cell lung cancer was considered as positive procedure, while today the same will not. We have a new category of sample that is diagnostic inadequate positive. I can tell you that we see a lot of patients that arrive to our observation with the diagnosis of lung cancer, but the pathologists say we have cancer cells. We can do diagnosis of non-small cell lung cancer, but we don't have enough material to proceed with immunohistochemistry, with molecular evaluation. So the aim of interventional pulmonology today is to get adequate tissue, not only diagnostic, but also adequate tissue. Well, we will see different steps to get this goal. The first one is to identify the most appropriate target, that not necessarily is the primary tumor. If you have cases like this, for instance, you can see that you have a peripheral nodule that is possible to approach, but it's easier to put a needle in the large lymph node in the subcarinal area. So it's easier to get adequate material for diagnosis, and in the same way to get staging of the disease. Identify the most appropriate target and select the most appropriate sampling technique and the most appropriate sampling instruments. You know that through the bronchoscope we could insert a lot of instruments. We could insert forceps, we could insert liquid, we could insert brushing. What is the most appropriate sampling technique? What is the procedure that suggests what is the most appropriate sampling technique? You know that CT scan is the procedure that every bronchoscopy requires to perform bronchoscopy. We cannot perform bronchoscopy without CT scan. And CT scan is the most important investigation that should guide the bronchoscopic strategy. In which way? It's very easy. From the bronchoscopic point of view, we should define three kinds of lesion that require three different techniques, three different approaches. The first one is central lesion. That means looking at the CT scan probably I will see something in the airways. And this means central lesion from the bronchoscopic point of view. The second is, as you can see, peripheral lesions. That means looking at the CT scan, probably when I will do bronchoscopy, I will see anything because the lesion is too peripherally. And the third one is that is a condition even more frequent in the last year, the hilar mediastinal lesion. The lesion is located outside the airway. The lesion is located in mediastinum. And again, this is another different condition. Central lesion. Central lesion is very easy to recognize for the bronchoscopic point of view. But in any case, also in such kind of lesion, we require tissue. We require histological diagnosis. One of these is not cancer. Try to identify. How many says the first on the left? No answer. Okay, I will suggest you. The first one is amyloidosis, is not cancer, but I'm sure that even an expert bronchoscopy may have difficulties to identify this and to answer to this question. So this is just to demonstrate that even when the lesion is easily visible in the airway, we require tissue. And we have different techniques to get tissue for central endobronchial lesion, but you can see that forceps biopsy is the technique that has the greatest sensitivity, low sensitivity for brushing and for bronchial washing. Transbronchial needle may have some rule, especially for lesion that does not involve the surface of the mucosa. That grow inside the mucosa or in the peribronchial area. So in these cases, needle can be useful. You can see here two lesions where needle may be useful. The first one is a lesion with a large necrotic component. You can see when you see white tissue, this is necrotic tissue, and probably to get forceps in this tissue means to get no vital cells, while putting a needle in the deep of the lesion may get more vital cell than forceps. And the second lesion where a needle can be useful are lesion highly with high vascularization, like that in the right side, the suspect of easy bleeding, induce bronchoscopies to test the lesion with a needle before using forceps. These are possible indications for needle. And of course, when the first bronchoscopy was not diagnostic. A new technique for biopsy that now is largely used by pulmonologists for the diagnosis of interstitial lung disease, but can be used also for neoplastic central lesion, is the cryo biopsy. There is this randomized trial performed in Germany where cryo biopsy showed the higher sensitivity in comparison to conventional forceps biopsy. You can see here the cryo probe that frees the tissue, and the tissue is attached to the probe that is removed with the tissue. And you can get large core of tissue, large biopsy with this technique. Central bronchial carcinoma, take home a message. Brushing and washing should not be used because of low sensitivity and poor evidence of adequacy of material obtained by brushing and by washing for molecular studies. A lot of people use broncholavage, but it's really useless in this condition. Needle should be considered when there is the suspect of intramural peribronchial lesion or when there is evidence of superficial necrotic tissue. And third point, don't forget cryo biopsy that could be used for difficult cases. Second point, peripheral lesions. You know that to approach peripheral lesion by bronchoscopy, a guidance system is required. The traditional guidance system is fluoroscopy. You can see here a bronchoscopic approach to a peripheral nodule, and the needle is inserted through the bronchoscope, and by fluoroscopy we can assess if the lesion is really centered. Now we have more possibility. We have the possibility to use an endobronchial ultrasound mini probe. You can see here that there is a movie, but it doesn't work. You can insert an endobronchial ultrasound mini probe in the periphery, and you can see, looking at the ultrasound, when the probe is inside the nodule, or if the probe is inside the nodule or not. And keeping inside a sheet, a guide sheet, and removing the probe, you can insert forceps or you can insert a sampling instrument. Another new system to navigate in the peripheral lesion is very close to the GPS of our cars. Is an electromagnetic field that is done around the body of the patient, and this electromagnetic field may localize a probe that is inside the airway, and this probe can be guided up to the target. Okay, however, these are very technical issue and is not very important in this setting. What I would like to underline is that the new technique of guidance, electromagnetic navigation bronchoscopy or ultrasound bronchoscopy, may increase the sensitivity of the transbronchial approach to peripheral lesion, especially for lesion less than 2 centimeters. However, message, don't use bronchoalveolar lavage for these cases. I don't know in the other countries, but in Italy it's very common when bronchoscopists see a peripheral lesion and don't see any endobronchial lesion to use bronchoalveolar lavage. Bronchoalveolar lavage in cases of lung cancer has very low sensitivity, less than 10%. So take-home message for peripheral lesion is don't perform bronchoscopy if you don't have the availability of a guidance system. The lavage has very small sensitivity. You are not required to have new technologies like HIBUS or like electromagnetic navigation bronchoscopy, but at least a fluoroscope to guidance your sampling instrument into the peripheral lesion is necessary. The third and the last issue is the hilar mediastinal lesion. We have no choice about the instrument of sampling. We require a needle because we have to go outside the airway to perforate the airway and to go into the mediastinal or hilar area. So we require a needle. We can use the traditional or conventional transbronchial needle aspiration that may have a good sensitivity, especially for large lymph node, greater than 2 centimeters, or lymph node located in the station number 4R or 7 that are very easy to approach with this technique. However, today the most used method to approach the mediastinal and the hilar area is the endobronchial ultrasound transbronchial needle aspiration, that is known with the nickname of IBUS TBNA. Well, with the linear ultrasound probe attached to the tip of the scope, you can see everything. You can see vascular structure, and you can see lymph node, and you can see in real time the needle that is doing a sampling of this enlarged lymph node with a sensitivity that is greater or equal to the sensitivity of mediastinoscopy in this field, 88%, or in the last paper more than 90%. The EBUS bronchoscope can be used also for other indication. If you have a small nodule like this one, look at the CT scan, you have a 8 millimeter nodule. What are you doing if you see such kind of lesion? Well, if you have a large bronchus close to the nodule, you can think that it's possible to wedge the tip of the echobronchoscope in this bronchus, and you can see the nodule by the ultrasound. So it's possible also to sample small nodule close to large bronchi to get diagnosis of these small 8 millimeter nodules that were a metastasis of genital urothelial cancer. Don't forget the esophagus. The esophagus is the last way that the pulmonologists learn to go through, because the echobronchoscope can be also inserted into the esophagus, and we can have more information for staging. Some lymph nodes are not adjacent to the airways, but they are adjacent to the esophagus, like station number 8 and number 9. We can get diagnosis of pulmonary lesion adjacent to the mediastinal pleural, and also we have a paper that demonstrates the possibility to get diagnosis of liver and left adrenal gland metastasis using the echobronchoscope inserted through the esophagus. You can see here a pulmonary lesion very close to the esophagus, and it's very easy to insert the echobronchoscope into the esophagus, and as you can see in the fluoroscopic view, and to perform a sampling of the pulmonary lesion, getting diagnosis in a very easy way. Well, take-home message: in case of an extrabronchial lesion, ileum or mediastinum, bronchoscopy should not be performed without availability of transbronchial needle aspiration in cases of large lymph node or EBUS TBNA. Is the material that we can get with EBUS TBNA suitable for molecular studies? There are a lot of papers in the literature about this, and I think that it should be confirmed that material obtained by EBUS TBNA is able to provide material suitable for EGRF mutation, for HALK translocation, and now also for identification of PD-L1 expression in lung cancer. After the sampling, we have to handling and processing the sample in the best way. This is the flow chart that was published in the American Journal of Respiratory Critical Care Medicine in 2012, and is the flow chart that we are following in our institution. The first step is needle aspiration of the target. The material is smeared on a glass slide, stained, and submitted for ROSE. If ROSE is positive, that means that we are in the target. So we can repeat the sample with the same technique in the same location, and the material is put in formalin for cell block or for histological evaluation. If ROSE is negative, it means that the technique must be repeated or changed. We have to change the location, we have to change the target. Smeared cytology and cell block are both performed with the same material, and you can see here the advantages and disadvantages of each kind of procedure. In any case, we performed both techniques. The last point is, of course, that to do this, we need a close cooperation with the cytopathologist, and this is a further support to say that the team approach for the management of lung cancer is today necessary to get the best treatment and the best diagnostic approach. In conclusion, bronchoscopy biopsy techniques are able to provide a cytohistological diagnosis in most cases of tumors located in the airway, in the lung parenchyma, and in the mediastinal. And the material obtained by bronchoscopy is suitable for histotype definition and molecular evaluation in most of cases. I thank you for your attention.